Okay, so here we are again, and today we are focusing on schizophrenia. Again, I say the same thing that I said yesterday. Why we need advances in the treatment of schizophrenia? Well, if yesterday we said that we needed advances for the treatment of depression because the current treatment are far from perfect, for schizophrenia the situation is even more complex because honestly we don't have at present treatment for schizophrenia that work completely. We can use pharmacotherapy, psychotherapy, rehabilitation, a combination of treatments that help the outcome of schizophrenia. But of course, we cannot cure completely schizophrenia at present. Probably in the future with some genetic studies or biological studies, but not at present. So this is why it's very important that first we know in detail all the available treatments that are at present in the market. And in the end of the presentation, you will see which are the possible future treatments that are coming that can help even more what we are doing. This is why we have to avoid to behave like in the ancient past and prescribe treatments that are maybe suboptimal or even completely inappropriate in some cases. To do this, we have to know all the antipsychotics that we have at present. They are many, they are different, and it's important that we know as much as possible the pharmacodynamic, pharmacokinetics, uses, indications, evidence of all of them. It's not easy, but in this presentation I will try to give you some indications, at least from literature and experience. Starting from the old ones, these are the labels. What is the indication of the drug? And as I always say, the indication is always the starting point. We should prescribe a drug where there is an indication or when there is scientific support from literature. Otherwise, we are completely off-label and we can have issues about that, of course. The old ones are mainly indicated for schizophrenia, acute and many of them chronic, some of them for manic disorder, and some of them other sparse indication. But I would say that none of them has any indication for depression in bipolar disorder or depression in unipolar disorder. Basically, the old antipsychotics do not have much room for use today, except the fact that they are cheap and, for example, for the case of haloperidol, could be useful for extremely agitated patients because of the very clear dopamine D2 blockade. But except for these rare cases, I would say that the old one do not have much room in the therapy now. The ones that are much more used today, in some places 90%, are the new ones. The point of the new ones is that the indications are very different one from another. So it's important that we have knowledge of when to use one or another. So just to start from the most famous, quetiapine. Quetiapine has indication for a lot of things. Acute schizophrenia, chronic schizophrenia, acute mania, acute bipolar depression, and prevention and stabilization of bipolar disorder. But it has also indication for as a just adjunctive treatment for major depression. It could be useful for insomnia, and it could be useful also for anxiety. It means almost all diagnoses. But this is the only case with so many indications, depending on the dosage, of course. Some other compounds are much more restricted, like clozapine. We will talk about clozapine later. Aripiprazole has indication for schizophrenia, bipolar, and we saw yesterday as adjunctive treatment in depression. And then there are the very new ones, lurazidone, cariprazine, brexprazole. We will briefly discuss this at a certain point during the presentation. They have some indication also for bipolar disorder, at least for the FDA, for the depression part of the bipolar disorder. So as you see, the new ones are a very heterogeneous category. And the newer ones, the ones that are coming in the future, that we will see at the end of the presentation, are even more heterogeneous. This is why it's important for us clinicians to know as much as possible about these new compounds and how to use them and when to use them. Then we have the depot, the long-acting antipsychotics. Here also we are quite lucky compared to a few years ago, because at present we have a lot of long-acting antipsychotics. In the past we had only 2 or 3, now we have more. My opinion on long-acting is that I'm very favorable of using long-acting antipsychotics for some reasons, one of which will be in the next slide. But starting from the more simple one is that the administration of a long-acting antipsychotic, I think, is more convenient than everyday tablets. In the past, I remember when I was starting this activity, long-acting antipsychotics were considered negative. Oh, we should use long-acting antipsychotics only for patients that are not compliant to oral therapy. Some kind of negative light on long-acting antipsychotics. But more recently, there is the impression that long-acting antipsychotics are probably even better than every day taking the pills. At least for the patients that I followed, I realized that many patients prefer to go once a month, or for some of them once every 3 months, to the hospital or to the outpatient unit to do the injection, because they feel that they don't take the medication every day. So also from a patient perspective, sometimes the long-actings are preferred to oral administration. We have many. Aripiprazole monthly. There are some kind of other aripiprazole a little bit longer. We have the usual haloperidol, olanzapine, with this story of the administration in the first 2 hours. We should be careful. Paliperidone, we use a lot paliperidone, and risperidone, not much used anymore. Probably there will be new formulations later. This is the first advances that I would like to tell you today. I told you about long-acting. I told you about the reasons of using long-acting. One reason that I'm telling you that probably is not so familiar, this is why it's an advance, it's a new information, I guess, for you, is this study that we have done quite recently, a couple of years ago, and it was replicated also by other people in the world. This is a nice study because we followed up few patients, these are 5 patients, but for a very long time, about 1 year. The take-home message is that this is paliperidone, 3 months, long paliperidone, not the short one. The interesting part of this study is that those patients, they were using paliperidone every day. Then they switched to paliperidone once a month, and then they switched to paliperidone every 3 months. The first point is that they were all stable. It means no relapse of psychopathology or schizophrenia. So clinically, they were well. But the very interesting part, and the new part, is that we monitored their plasma level. And the plasma level, when they were taking the medication in tablets every day, when they took paliperidone once a month, and when they took paliperidone every 3 months, the plasma level decreased and stabilized at a very low level that is less than the threshold of efficacy. So it means that those 5 patients, after 9 months of paliperidone 3 months, had in their blood less paliperidone than in the usual range is considered to be therapeutic, but they stayed well in the same way. We discussed a little bit this finding in the paper, and there is also another paper in literature. that is very interesting from a pharmacologic and pharmacodynamic perspective. Because if you think when you take tablet every day, the plasma level when you take the tablet goes up after 2, 3 hours and then goes down and then goes up again and then goes down. So the average plasma level is not the peak, of course. You have to consider also the bottom. So this is why for oral administration, you have to stay much higher. And this is why the guidelines are based on the oral administration range. But when you give it once a month, the curves are much smoother. Every 3 months are even more smooth. So you can allow to have a plasma level that is below the range because it's stable. So the effect on the dopamine and serotonin receptors is always the same. This finding, I think, is very important because it allows you to keep the patients at a dosage of the paliperidone in this case, but all antipsychotics, much lower than the usual range. And this, of course, is a big benefit in terms of tolerability, side effects, long-term neurological side effects, and so on. Of course, patients must be monitored and so on, but I think this is a very nice point. Let's go on about other topics in the decision about antipsychotics. As we discussed yesterday for antidepressants, let's answer to the most basic question, which is the antipsychotic that is more effective than the other? And then I suggest you to again look at the Mosley guideline, and the short answer is there is no one that is clearly superior to the other, except probably clozapine. And the usual meta-analysis by the Oxford group, by Cipriani and colleagues, indeed somehow confirm this finding. This is the most recent one that they produced. And if you look at the about 30 antipsychotics that we have, differences are very small, except for the ones that we know that are more delicate, like cariprazine or lurasidone. But the difference is very small one to another in terms of overall efficacy. And so it applies the same concept that we discussed yesterday for antidepressants. Overall, they are very similar, but they are different in their pharmacodynamic profile. So we have to consider each of them for the specific patient. Pharmacodynamic profile means that we have to know what happens in the brain. This is the dopaminergic system with its good and bad activities, you know, the frontal, dorsolateral prefrontal cortex, the motor areas. So when you manipulate the dopaminergic system, you change a lot of things in the brain. And recent antipsychotics change not only the dopaminergic system, but also the serotonergic system and many other systems as well. This is why it's important to have a clear view about each of the antipsychotics that we are using, what is doing in terms of pharmacodynamic activity. Just few examples. This is a table, but you can use many other similar ones. Dopamine D2. Dopamine D2, of course, is probably the most important target of antipsychotics, the oldest one. And depending on what you do on dopamine D2, you have consequences. So, of course, the more you block dopamine D2, the more you reduce positive symptoms. But the more you do this, the more you have neurological side effects and all the long-term side effects that we know. And so drugs differ in terms of blockade of D2. Some more, some less. Quetiapine less, clozapine less, haloperidol more. Then we have the partial agonists like aripiprazole, that as I said yesterday, they block 30% of the dopamine. They produce 30%, they stabilize at 30% the dopamine turnover. So this is a different mechanism of action. Then we have the other dopamine receptor. We have all the serotonin receptors that we will discuss a little bit later. Each of them with a different effect. The 1A, the 2A, and the 2C are probably linked with some antidepressant effect. So as much as a compound acts on one of these, we can have a different antidepressant effect. And then we have the alpha-adrenergic, the muscarinic, and histaminergic that are globally linked with sedation and weight gain. So I always say that we should have in mind how these different compounds bind to the different systems and then adapt to the single case. We need a more sedative antipsychotics for sleeping. We need a more antipsychotics more active on the positive symptoms, but we don't want weight gain. So we have to consider all of these pharmacodynamic profiles. Is that? So the principles to use when we have to prescribe an antidepressant, an antipsychotic, is very simple. First, we have to target the symptom. Every patient is different. Every patient has a different composition of symptomatology. So first, we have to collect. Is the patient more on positive symptoms? The patient is more on negative symptoms. We'll see later that there are something there. Is the patient with comorbid medical disorders? So we have to collect all the information of the patient. And then we have to target and match the pharmacodynamic profile of the antipsychotic with the symptomatology of the patient. More sedative, sleep-inducing, or on positive symptoms, on negative symptoms, and so on. We have to collect the information from the past efficacy. Maybe a patient had benefit from a specific compound. This is a very important information. Similar to what we said for antidepressants, if compound is not working at all for a reasonable period of time, then we have to switch. If the compound is doing some small but present benefit, then it's better to go on and maybe to do a combination or augmentation as well here. If there are, of course, negative reactions, we have to switch. Combination, we discussed yesterday that combine two antidepressants doesn't have much support from evidence. Combine two antipsychotics, even less. So, unless there is a very clear indication to combine two antipsychotics, we should never combine antipsychotics. This is a long story. We don't have time to discuss this today. That has been discussed a lot in literature. There is no scientific evidence to combine two antipsychotics since the beginning or unless it is particularly needed. Nevertheless, more than half of the psychiatrists in many countries, they combine antipsychotics. I remember a paper about 56% of UK psychiatrists combine antipsychotics in schizophrenia, even if there is no scientific support on that. The last point is that the dosage should be used as low as possible. You remember yesterday we were discussing about the antidepressant. Use the highest dose tolerated to be sure that the antidepressant is working. For antipsychotics, is the opposite. We should use the lowest dose that is effective. Why? Because antipsychotics give much more side effects compared to antidepressants. So we must be very careful in prescribing high doses of antipsychotics. This is that. That. Alive. About doses, I mentioned this paper that we did a few years ago with our German colleagues about the dosing. In this case was of alloperidol. And we identified a dose range that this is the plasma level, this is the oral dose, it is across 10 milligrams more or less. It is the optimal dose. Why? This is a very nice graph that we did in the past. At the time, we got credit to do this graph that is quite complicated, honestly. That is a three-dimensional graph about the improvement in the first 2 weeks, the plasma level of alloperidol at third week, and the improvement after 4 weeks. The idea was to see if a patient was not improving at the beginning of the treatment, and then you increase the dose of haloperidol. This is their psychotic, PANS, psychotic symptomatology. So patient not improving in 2 weeks, you increase haloperidol. Is it good or not? This was the question. And if you look at the graph, the answer is very clear. So we have some patients that had a very good improvement. This is 0.6 standard deviation. That is a large part of improvement, so good improvement. But we had also patients who did not improve at all, 0 or worsen. What happened after another 2 weeks? Some of these patients received an increase of haloperidol. This is very high plasma levels. If the increase of haloperidol was useful, we should see here a rise of this curve, but it did not happen. So it means that when a patient is not improving much after 2 weeks, there is not much point in increasing a lot of the dose of the drug because it does not give added benefit, except for specific cases that are very rapid metabolizers. But in general, this is the rule. So this is a demonstration that we should stay as low as possible with the doses, particularly for compounds that have a tolerability profile that is not so good, like haloperidol. Okay, so we discussed a little bit the efficacy. Just a few slides about the pharmacodynamics. So we have to have a clear idea of which is the profile of the compound that we are using. Dopamine D2, this is the star, obviously. Dopamine D2, the serotonin, serotonin receptors, melatonergic receptors, adrenergic receptors, and so on. And the compounds that we are using are very different one from another. For example, talking about serotonin 1A, that is important for antidepressant effect, they are not all the same. For example, all the pines, olanzapine, clozapine, quetiapine, they have more effect on the 1A compared to the DONs that we know that are less effective on the antidepressant part. Then there is the 2C. 2C is another receptor that is quite important for the antidepressant effect. And about 2C, we have some of the compounds that, like the pines again, have a very good binding, while others, like the DONs, have much less. So again, this is a confirmation of the complex, sorry, the complexity of the pharmacodynamic knowledge about the compounds that we use. Few words about the dopamine complete or partial blockade. Complete or partial blockade. We did a study a few years ago, this was 2009, about the importance of knowing how to manage when you combine drugs with complete or partial blockade. When you switch to aripiprazole from haloperidol, for example, or risperidone, you have a complete blockade of the dopamine D2 with haloperidol and risperidone. And then you have a partial blockade of dopamine D2 with aripiprazole. It means that you go from 0, if you have a complete blockade, to 30% of dopamine with aripiprazole. So you must be very careful when you switch from haloperidol or risperidone to aripiprazole, because if you do it too quickly, you have a spike in dopamine that is negative for our patients. And indeed, we compare that if you switch abruptly, without any waiting, just one day to another, you have a worsening of the symptomatology of the patient. Haloperidol or risperidone before, and then aripiprazole. If you do it slowly, you have a much better benefit. At the end, both groups have a benefit from the switch. but it depends how you switch. So it's important that when you change one antipsychotic to another, you have to think which is the pharmacodynamic profile of the antipsychotic. If they have a different binding to the, for example, dopamine D2, you must be very careful. But the same applies for the muscarinic or histaminergic receptor. If you switch from olanzapine to haloperidol, of course you have a rebound insomnia. So the switch of antipsychotics must be managed very carefully, and you should go slowly depending on how different the two antipsychotics are. If the antipsychotics are very similar, you can do it in a few days or even one day. But if they are different, you must go very slowly. This is another paper that we published in my journal, by the way, just now, that Matteo did a study that we discussed a lot to answer a question that was not clear in literature. So I like a lot this paper. The question is it reasonable to combine a complete dopamine D2 blocker with a partial dopamine D2 blocker? Because we discussed in the previous paper 15 years ago that if you go from a complete dopamine D2 blocker, haloperidol, to partial aripiprazole or cariprazine, then you have to do it very carefully. But can you combine them? Is there a reason to combine, for example, haloperidol or risperidone with aripiprazole or cariprazine that are partial dopamine D2 blockers? Is there a reason? Because in practice, we see that many people does it, but the pharmacologists are mixed. Is it reasonable to give two compounds that do opposite effect on the dopamine D2? And then we did a review of the evidence, and the results are very interesting because we saw that some results in literature show that there is an improvement when you combine a partial with a complete dopamine D2 blocker. Some suggest that there is a worsening or no effect. The key to understand is that the improvement you see when the patient have first a shorter history of disease. So it means that probably they didn't have these long-term changes in the dopamine system that somehow impair the dopamine system. So early patients, few years. And second, the benefit was evident after few weeks, not at the beginning. This reflects a lot in clinical practice to tell you that when you have a patient with complete D2 blocker that probably is not completely effective or there are some residual symptoms and you want to add, for example, negative symptoms, but you don't want to change the compound because it was a little bit effective, then you can add the partial blockers, aripiprazole, cariprazine, provided that the patient has not a very long history of disease and you have to wait a few weeks to see the effect. And this was the first time that was reported in literature, and I'm very happy that this small but very useful point could be done. Then a few years ago, we did another study comparing, this was more standard study, comparing paliperidone and aripiprazole. But they are both effective with small differences, but in any case, this supports the use of long-acting antipsychotics. This I showed you yesterday about the stability of the plasma level in renal failure. And one of the final points of this section, I wanted to focus on the problem of clozapine resistance. We have difficulties in finding and choosing the antipsychotics, but we also have difficulties when the antipsychotics don't work. So what should we do when we go to clozapine and clozapine itself is not working well? We did this study and there is evidence that you should do a combination. In this case, is correct to do an augmentation or combination depending on what you do. With what? There is good evidence of clozapine plus risperidone, even though there are some negative studies. There is good evidence on clozapine plus aripiprazole. There is good evidence of clozapine plus amisulpride. So these are the main and strongest suggestions how to improve the efficacy of clozapine. The other are much less. I would like to focus a little bit on here. There are only 3 studies, but all of 3 are concordant of fluvoxamine. In my experience, I used fluvoxamine in schizophrenia. There is some evidence in literature. Indeed, except for the pharmacokinetic interaction, they should be controlled. But fluvoxamine is indeed one of the most useful, probably, antidepressants in schizophrenia. Good for mood, good for negative symptoms. So fluvoxamine is a good option. Probably also mirtazapine, not for sure fluoxetine, and not many other indications. Last point of this part of the presentation, tolerability. And this is, of course, linked to the pharmacodynamic profile. If an antipsychotic is more muscarinergic or adrenergic, you will have hypotension, you have weight gain. So these are the side effects that you can expect, akathisia and Parkinsonism, if they are binding the dopamine system, sedation, weight gain with the other system that we discussed. Another important point is the QTC, heart. So we have to consider which of them are higher risk of electric dysfunction of the heart, and some of them have no effect at all, some have low effect, some have moderate effect, and some have high effect. This should be considered for delicate patients, elderly patients, or patients with cardiac medical diseases. Sexual side effects of antipsychotics are also quite different one from another. Of course, some are very high, like haloperidol, risperidone a little less, olanzapine, aripiprazole less, and quetiapine is the one that is less than all the others, particularly at low doses. This is to be considered. To be considered also the possible remedies for sexual dysfunction. One of the most interesting is bupropion that could be used, or pimavanserin. We will discuss this a little bit later. And the usual sildenafil, of course. Weight gain also is important for antipsychotics. Clozapine and olanzapine are the strongest, but some less. And there are also some remedies for weight gain to be considered. Aripiprazole, bupropion again, fluvoxamine, or now there is much discussion about the use of metformin to counterbalance weight gain of antipsychotics, and some other suggestions that you can look later. Final few words for brexpiprazole. Brexpiprazole is a small change compared to aripiprazole. You don't have, I think, in your country, but it will arrive soon, I guess. Still a partial dopamine D2 agonist, but is more sedative compared to aripiprazole. I wrote opinion paper about brexpiprazole, and indeed, reviewing the evidence on brexpiprazole, and we have in Italy, so I started using it, indeed is more sedative than aripiprazole, and in this way is a little bit more useful for some cases. Doesn't give the agitation of aripiprazole sometimes, doesn't give the sleep problems of aripiprazole that you can see in some patients. So for some patients, brexpiprazole could be a good option. Okay, we are at the end of the presentation, the last 2 slides. What is the future of antipsychotic treatment? So which are the future advances of antipsychotic treatment? We discussed so far how to optimize the current available antipsychotic treatment, but in a few years we will have new one. One of the most promising is this one, olotaront. Oloterant is a very nice discovery. Is at present at phase 3 study. Could be in the market very soon because FDA gave a breakthrough channel for this. It is extremely interesting because this is an antipsychotic that, at least from the data that we have now, is as effective as the present antipsychotic, but with almost no side effect. And this is something that we don't have for any antipsychotic at present. So if the findings are confirmed in the larger phase 3 study, this could be a game changer for schizophrenia. Extremely well tolerated because it doesn't go on the dopamine D2 or the serotonin 2A to C and so on. It goes in a completely different system. We don't know exactly at present, but probably goes on the TAR system. So completely in another system compared to the dopaminergic and monoaminergic system. So this is probably the most interesting perspective that we have. But we have a number of many other uh, minor sometimes, but useful as well possibilities. Just a few of them because we don't have time to go through of them. The first one is interesting because it has been approved by FDA a few months ago. And it is an alpha adrenergic modulator for agitation. Of course, it's not a game changer, but it can be useful in some patients. Then we have a MAT2 inhibitor that could be useful for tardive dyskinesia modulation. Then we have this new brilaroxazine that is partial D2 and partial serotonin modulator, so could be even more well tolerated compared to the partial modulators that we have now. We have the pimavanserin for negative symptoms. It goes only on serotonin 2A. This is another possibility to combine with antipsychotic treatment. This we already discussed. CARXT is another interesting compound that goes on the muscarinic receptors. So it seems that it modulates a little bit symptomatology. Also, this is quite promising. Roluperidone, probably results are not so strong at present. Dextromethorphan is another useful treatment that is used also in depression for negative symptoms. It goes on the glutamatergic system, so this could be of help for patients with negative symptoms. We have this glycine transporter inhibitor, could be good for cognitive impairment, but data are not so many at present. Sodium channel blocker. And then we have the new long-acting antipsychotics, risperidone. Probably this is, it could be kept at room temperature, that is more convenient. And the 2-month aripiprazole that should be ready soon. So as you see, a lot of new compounds are appearing for schizophrenia, and therefore we must be updated to use them in clinic when they are available. So I think this way I'm finishing my presentation. I would like you to remember from this presentation that antipsychotics that we have are many, more than 30. We have to know them well, each of them, pros, cons, good things, bad things, when to use them, how to match to the patient. There are coming new antipsychotics. Some of them are very promising, so they could be very useful in clinical practice. We have to be updated on the new developments to be ready to use them in practice. Thank you.